5, 4, 3, 2, 1. Can we start, ma'am?
Good afternoon, one and all. Now comes the time for which we all have been eagerly waiting, the much awaited live cadaveric rhinoplasty demonstration by Dr. Sunil Tawar. Sir is the founder secretary, Rhinoplasty Society of India, Director, Jaipur Durbin Hospital and Naksh Rhinoplasty Center, Director, Global Rhinoplasty Fellowship Program. Dr. Sunil Tawar has contributed to the field of rhinoplasty abundantly, justifiably and undoubtedly be called the face of rhinoplasty in the modern era. I once again welcome you, sir. The moderators for the session would be Dr. Pradeep Goyal, Senior Professor, Department of Plastic and Reconstruction Surgery, SMS Medical College and Hospital, Jaipur. Dr. Sandeep Pond, Consultant Facial Plastic Surgeon and Chairman, European Board of Examination for Facial Plastic Surgery, London. Dr. Amar Singh, Senior Consultant, ENT and Rhinoplasty from Abu Dhabi. Dr. Lokesh Kumar, Senior Consultant and HOD Plastic Surgery, BL Kapoor Hospital, Delhi. He is also the Vice President of Rhinoplasty Society of India. Dr. Tarun Ojha, Professor and HOD, Department of Otorhinolaryngology, Mahatma Gandhi Medical College and Hospital. Sir is also the Secretary of AOI Rajasthan. And Dr. Satish Jain, Senior Consultant, ENT, Head Neck Cancer and Skull Base Surgery, Director, Jain ENT Hospital. The chairpersons for the session would be Dr. Deshbandhu Jain, Dr. Monish Grover, Dr. Navneet Mathur, and Dr. DC Khatri. Sir, I hand over to you, sir.
Okay, thank you. Good afternoon, everyone. First of all, my heartfelt thanks to Tarun Ojha, boss, and entire medical college, Mahatma Gandhi Medical College, and Sandeep sir, Pradeep Goyal sir, and my special thanks to Sun Pharma person also. Whenever we ask them, then they always ready for the any academic event. So today we discuss about the cadaver dissection demonstration anatomy, and we learn some tips and tricks of the rhinoplasty. But before to start the dissections, we just discussed that why this rhinoplasty surgery is most difficult to any other facial plastic surgery, because mostly the rhinoplasty usually unavoidable surgery by the ENT persons. So there are certain challenging factor. That the first challenging factor, that the great variability in the anatomy. Nose have a variable endless anatomic variations. And the second important factor that make it the challenging, rhinoplasty surgery need the form and functions, and it's really a balance between the cosmetic and the functional issue in the patient. If we do a good rhinoplasty surgery and the patient have a very beautiful nose, but if the functionally if the patient problem, then it's not good for the patient. So this surgery need the form and the functions, so it make the more challenging surgery. And the third, when you do the surgery, then your results match with the expectations of the other persons. So these three factors make it the more complicated surgery in all aesthetic surgery rather than other surgeries. Now, before to discuss the for opening of the nose, first just we discuss some important like surgical landmark of the nose for study purpose, for the systematic approach. This is a one important advice me for my junior colleagues. Whenever you go for a cadaver dissection course, then I think you go for the systematic way, not just open the nose and then you just finish your dissections. I think you should just study first your outer soft tissue envelope, important surgical landmarks regarding the blood supplies and how you evaluate the skin thickness. These all things are important. Then systematically you open your nose. So for the systematic way and for the study of this entire nose pyramids, we can divide this nose in the three part. So first the upper one third, and the mid third, and the lower one third. So each third part of the nose that have their own framework. The upper one third, the bony vault, this bony vault, this bony vault made up by a pair of nasal bone. And then the mid third, the inner framework of the mid third, that is formed by a pair of the upper lateral cartilage, T-shaped upper lateral cartilage, and the lower third of the nose that is formed by the LR cartilage, a pair of LR cartilage, that is the lower lateral cartilage. And from the top to bottom on the under surface, first the bony septum and the cartilaginous septum and the membranous septum. These all three upper third, the mid third, and the lower third, they cover by the soft tissue envelope. So this soft tissue envelope, outer covering, have their important surgical landmark and their own blood supplies. And so first we study each landmark, the some important surgical landmark. So I think they all landmarks should know for everyone when you start of rhinoplasty career or rhinoplasty surgery. So the important surgical landmark regarding the bony vault, first that is the glabella. So glabella is a most prominent point on the midline of the forehead. This is the glabella, usually fall between the eyebrow. So the importance of this glabella, if we go for the clinical importance of this glabella, a very important muscles arise from the glabella. That is the procerus. And we also measure a important aesthetic angle from the glabella, that is the nasofrontal angle, because the nose have the two angle that usually we discuss during the rhinoplasty. One is the nasofrontal angle between the forehead and the nose, and another is the nasofacial angle, nasolabial angle between the nose and the upper lip. So we also measure the length of the forehead from this glabella to the trichion when in aesthetic surgery. So this is the importance of the glabella. Now the second important point, that is the radix. Radix is basically a distance of the frontonasal sutures. Radix is the distance of the frontonasal suture. And the deepest point on this frontonasal suture, that is the nasion. So the starting point of the nose, the root of the nose, that is the radix, but the deepest point on this frontonasal suture, that is the nasion. And whenever you do the transverse osteotomy, never go above the nasion. We always below the nasion. Then third important, that is the rhinion. Rhinion is the osteocartilaginous junction between the bony vault and the cartilaginous vault. So the two important point regarding this rhinion: one, we have a very important area below the rhinion, that is the keystone area. So the keystone area is the confluence of the four structures. One is the nasal bone, and another is the upper lateral cartilage, and the bony septum, perpendicular plate, and the cartilaginous septum. So this upper lateral cartilage get maximum support from this area. So you always maintain the integrity of this area, because sometimes, especially during the crooked nose, during the osteotomy, this K-stone area is disrupted. So once this K area is disrupted, it's very difficult to reconstruct it by the especially by the junior colleagues. So you always maintain the integrity of the K area. When we open the nose during the osteotomy, then what exact anatomical attachment of this upper lateral cartilage and the nasal bone we see later, because in the K area, this upper lateral cartilage and the nasal bone, this nasal bone, just distal part of the nasal bone overlap on the cephalic part of the upper lateral cartilage. And this overlapping is maximum in the keystone area, around 9 millimeter. So that's why this upper lateral get maximum support from this area. So This the keystone area is important. Then another important thing on the rhinion, the skin thickness. If you compare the skin thickness from the top to bottom, then in the nasofrontal area, the skin thickness is thickest. But on the other hand, in the rhinion area, the skin thickness is thinnest. And in the tip vault, the skin thickness is highly variable. So it's my personal advice that whenever you open the nose during the dorsum dissection, then you great care should be taken, especially in the rhinion area. So these are the important surgical landmark regarding the bony vault. And on inner side, the attachment of this nasal bone in the center, this nasal bone, and the superolaterally, that is the lacrimal bone, and the inferiolaterally ascending process of the maxilla, and the superiorly the nasal process of the frontal bone, and inferiorly with the upper lateral cartilage, and on underside, on the underneath, the bony septum. So these are the important attachment of the nasal bone. Now, the second part is the mid vault. Dr. Pond always mentioned that this mid vault that consists by a upper lateral cartilage. So this upper lateral cartilage is a very important. This upper lateral cartilage act as a subserving cartilage because it have the attachment from the upper part, the lower part, the medial part, the lateral part. All attachment are the important. So medially this upper lateral cartilage attached with the septum. So this attachment have a specially configurations at the 10 to 15 degree angulations, that is the internal nasal valve area. So we always maintain the integrity of the internal nasal valve area because patient get the maximum airflow through this internal nasal valve area. So if we disrupt this nasal valve area, then we recreate it by the spreader graft or the flaring sutures. So this internal nasal valve area from or the mid vault is important. And then the lateral most attachment of this upper lateral cartilage, this attach with the wedge of bone at lower end of the piriform aperture, just anterior and lateral to the head of the inferior turbinate. So this attachment is also important because during the osteotomy, if this area is damaged, then what happened? This entire lateral part of the upper lateral cartilage is medialized. And another important thing, because on the same location, the head of the inferior turbinate is also attached. So if this attachment is damaged, then this entire structure is medialized. So consequently, the patient develops the nasal blockage later. So these two attachment, medially attachment and lateral attachment is important for the upper lateral cartilage. Then the third, the last, this lower third part, we can divide in the 4 subunit for learning the important surgical landmark. The first, this most anteriorly projected part, that is the tip lobule. So on this tip lobule, there is 2 light reflecting area, that is the tip defining points. These are the tip defining points, and the distance between this tip defining point, that is the width of the tip. Okay, ideally this tip defining point, the distance between the 6 to 8 millimeter, and on dorsum, where the tip end and the dorsum start, or we can say where the dorsum end and the tip start, that is the supratip brake. And anteriorly, where the tip end and the columella start, that the infratip brake. So if we met all these 4 points, then there is a isosceles triangle that have the equal apex and the lower half equal, that is the diamond tip concept. So these are important landmark regarding the tip lobule. Then the second subunit of the lower vault, that is on either side of lateral to this tip lobule, that is the ala lobule. These are the ala lobule. So the ala lobule, attachment of the ala lobule with this lip and the cheek, that is the nasofacial groove. This is the nasofacial groove, and this is the ala base. This is the base of ala. And this free margin of this ala, that is the ala margins, and the convexity of this ala margin, that is the flaring of the ala. So this is the ala flaring. And another important thing, the attachment of the ala with this tip lobule, that is the supraalar groove. This is the supraalar groove. So this is the second unit of the lower third of the nose. And the third, between these ala lobule, this important vertical structure, that is the columella. So the vertical part of this columella, that is the pillar of the columella, and this broad base of columella, this is the footplate of the columella. So this columella basically divide this entire nasal cavity in the two symmetrical equal part. So this is the third subunit, and the fourth and last subunit is the nostril, just on either side of the lateral to the columella. So the orientations of this nostril cavity is important. The nostril cavity is pear-shaped and always oriented medially around the 45-degree angle. And on apex of this nostril cavity, a very important structure, that is the soft triangle. This is the soft triangle. So the importance of the soft triangle, whenever you go for the marginal incisions, then if there is a minor injury in this soft triangle area, then consequently the patient develops a notching post-operatively. That is very difficult to treat, because in soft triangle area there is a very scanty and few subcutaneous tissues, and there is a skin to skin approximation there, because we have a dome notch. Later when we open the nose, then we see that. So this is the importance of the soft triangle. And on the floor of this nostril, this posteriorly placed cylindrical area, this one, this is the sill of the nose. This is the sill of the nose that decide the size of this nostril. So this is the importance of the anatomical knowledge of the nose, because if you don't know what underlying deformity under the skin, either do a patient have the ala flaring or the ala base problem, then how we can correct it. So for the correction of the abnormal anatomy, you know the normal anatomy first. Now, after the important surgical landmarks, the second important thing, the blood supply of this soft tissue envelope.
So, Dr. Sunil, you described all the landmarks very nicely, precisely.
Yeah.
Can we know what is celion, and how does it differ from rhinion?
Celion is basically is the osteocartilaginous junctions. There is 2 points. One is the soft tissue point. The soft tissue point is basically rhinion, and the celion is the regarding the bony part. That is the celion. So now the next is the blood supply of the nose. So for the learning of the blood,
what is significance of celion and
it's nothing the specific significance. Basically, it's the junction of the bony junction of the basically osteocartilaginous junctions. And when we put the soft tissue envelope over it, then that is the rhinion.
Okay.
So the blood supply of the nose come from the two system. One is the ophthalmic artery system, and another is the facial artery system. From the ophthalmic artery systems, one is the dorsal nasal artery, that is the terminal branch of the ophthalmic artery, and that emerges from the medial most part of the orbit and run over the dorsum. Red color का marker नहीं होगी. कोई sketch है क्या red color का? यही दे देना. बिजना. देना. विजय को बोल दे. So this dorsal nasal artery emerges from the medial most part of the orbit and run over the dorsum and supply the upper part of the nose. कोई भी ball pen भी दे दो, and कोई भी ball pen या sketch pen. And another from the facial artery system. From the facial artery, this gives the two branches. One is the superior labial artery at the angle of the mouth. इसको यहाँ पे करना, इसको यहाँ पे करना, थोड़ा सा नीचे करना. यहाँ पे करना, focus करना please. So at the angle of the mouth, the facial artery gives the two branches. One is the superior labial artery, and the superior labial artery run along this upper lip, and at the on the base of this columella, this gives a pair of branches, that the columellar vessels. So this is the superior labial artery, that is the branch of the facial artery system. Another branch of the facial artery system, that is the angular artery. So this angular artery run above and at the level of the nasofacial junctions. It gives again some branches, that are the lateral nasal arteries. So this lateral nasal arteries and branches of the columellar vessels have some anastomosis at on just cephalic part of the lateral crust, that called the LR arcades. And the branches of the lateral nasal arteries, इसको ऊपर कर देना, branches of the lateral nasal arteries and some branches of the dorsal nasal artery have the anastomosis also, and then make the subdermal plexus. And these subdermal plexus and LR arcades are above the basically above the smash layer. So below the smash is the completely avascular layer. So the importance of this blood supply of the nose, whenever you inject the filler, whenever we inject the filler, then if you are in wrong plane, then due to the retrograde embolizations, the filler ultimately reach in the central artery of the retina through the anterior and the posterior ethmoid artery. And all of us know then central artery of the retina is the end artery. So consequently, the patient develop the blindness. And 38 cases reported of the blindness. So you know about the exact depth of the where you are the inject the filler. So this is the importance of the blood supply of this nose pyramid. Another important thing, in open approach, whenever we open the nose through the transcolumnal incision, we make the transcolumnal incision for raising the flap. Then in that case, we severed the columella vessels. So now the entire blood supply of the tip, that is dependent through the lateral nasal arteries. So during the ala base excisions, if our incision is more than 2 millimeter outside this one, then we can damage this lateral nasal arteries. So the incision should be in the nasofacial groove. This is the importance of the blood supply. And another important thing, during the defattening of the tip, when we defattening the tip, during the defattening of the tip, if you do the aggressive defattening, then you can damage the subdermal plexus. So there is a chance of the skin necrosis. So care should be taken when we defattening of the thing, then don't do the aggressive dissection, aggressive defattening. So now, after the important surgical landmark and the blood supplies, a important thing, that is the skin thickness of this soft tissue envelope. Whenever we examine the nose, then you always examine the thickness of this soft tissue envelope, because in mostly Indian patients, the patient have the thick skin, and ultimately whenever a patient have the thick skin, then it affect the outcome of the surgery. Definitely we have a certain advantage when the patient have the thick skin, because it hide the minor irregularities, and the graft material better tolerated in thick skin patient. But on the other hand, we need a lot of work to change the appearance of the nose. We need lot of graft for the getting the definition in the nose. And sometimes whenever we put a lot of graft, then the nose size is big. So you always keep all these things, because if you examine properly, then you explain to the patient about the prognosis, because it will take time later post-operatively for getting the definitions. So you always basically examination the thickness of this soft tissue envelope. And if your patient need any skin treatment, definitely you refer the patient for a skin specialist, or to give the proper treatment for skin treatment. Dr. Pon, sir. Hello.
Hi.
Uh, uh, can you send your all patient for the skin treatment, or you do the skin treatment to the patient? If a
No,
patient,
I don't. I don't. I send them to a dermatologist colleague, and we don't do it pre-operatively. We do it post-operatively. I mean, one of the problems, as you know, with any kind of skin treatment, if you're talking, are you talking about isotretinoin and things like this, or are you just talking about general skin treatments?
okay,
I
how
mean,
long?
if you're going to put patients on isotretinoin, then obviously you will need to leave some time before you operate on them again. It's very controversial. Some dermatologists actually believe that you can pretty much operate straight away after the patients have come off isotretinoin, but I think you have to be careful about it. So I think anyone who I see who's on isotretinoin, I'll get them to wait ideally about 6 months before they have the surgery after they've been off. But some patients with very thick skin, we put on isotretinoin after their operation, and that seems to be fine. But I don't do that myself. I send them to a dermatologist.
Okay, thank you. Now, before the start the dissections, one more important step, the infiltrations. So when the local infiltrations, the infiltration is essential and important step for the atraumatic dissections or the hemostasis. So for understanding the infiltrations, we can, I usually use the 2% lidocaine and around the 10 ml 2% lidocaine, that is the in 1:1 lakh, that is the enough. And I use usually the 5 ml syringe and this 26 gauge needle and 1.5-inch needle for the infiltrations. And for understanding the infiltrations, you can divide in the 5 steps. So the first step, you always nasal speculum, you infiltrate first in the septum. You infiltrate first in the septum along the margin of the incisions, and in the subpericondial or subperiosteal plane. So some renowned rhinoplasty surgeons, they usually infiltrate only along the margin of the incisions, along the site of the incisions. But I think it's better if you infiltrate on the both side of the septums. Dr. Hosam, they always infiltrate only on the site of the incisions, and they usually do their septum work with the hemitransfixation incisions or the Killian's incisions. So first you infiltrate in your septum on both sides, and then you pack it, and the second infiltrations in the columella for the transcolumnar incisions. So for the transcolumnar incision, you infiltrate either from the tip defining point to the anterior nasal spine, and never infiltrate too much, either 0.2 ml or 0.3 ml. And then between the tip defining point, between the dome area and the tissue between the dome area and surrounding the dome area. So you see the blanching, and after infiltration, you just massage it by index finger and the thumb, just to spread the local.
So apart from this local infiltration, which anesthesia you prefer during surgery?
I always prefer in the general anesthesia. Anesthesia. Dr. Pon, sir, I think. Sir, your all cases in under general anesthesia or in the local anesthesia you do there?
No, always under general. Always under general. It's I mean, we use a variety of different general anesthesia. I mean, some are under just TIVA, sort of total intravenous anesthetic, but the majority of time my anesthetist just gives them a full general. The only time I'll use local is if we're just doing a small touch-up procedure. So very rarely. I mean, I know some people do them under a sort of a more IV tubeless anesthetic, like a lot of in the US. This is done quite a lot because they have their medi centers. But I think often these things are done partly because of the consequence of what if you're operating in your own surgery center and you don't have permission for a general anesthetic, then people sort of do it by tubeless anesthesia. But for me, I like the surety of there being a tube, there not being any problems with anesthesia. And I like to, you know, I in my training, I even worked for a surgeon who used to give his own anesthesia and have an anesthetic nurse there with him, but he'd be sort of monitoring the anesthesia. For me, I don't want to be doing that. It's hard enough concentrating on your surgery.
Yeah, definitely.
Rather than you worrying about the anesthesia side of things. So yeah, no, a general anesthetic, 99% of the time, yeah.
Okay. Thank you, sir. So now the third site of the infiltration, that is along the margin of the lateral crus.
So would you ask for hypotensive anesthesia from the anesthetist?
Yeah, definitely the hypotensive anesthetist here. So the third site is the along the margin of the marginal incisions. So for marginal incision, you always palpate the margin of the lateral crus by a handle of knife or a cap of syringe. So you infiltrate along the margin of the lateral crus, and the margin of the middle crus, and you also in the vestibular skin and on both sides after the infiltration. And this is the third site for the infiltrations. And the fourth site of the infiltration on the dorsum. Dr. Pond always mentioned that you never infiltrate on the mid of the dorsum. You infiltrate on 1 centimeter on either side of the midline. This is okay, sir? Because
yeah, I agree. Because I think the problem is if you infiltrate over the dorsum, it distorts your dorsum, the soft tissue skin, and particularly when you're doing an open approach where you're lifting that skin up, it can cause quite a lot of distortion. So I like to just inject where you are laterally and just lateral to the midline, and then I'll use then I'll sort of massage that infiltration upwards a little bit, but not right over the dorsum itself. Plus, I think the thing is, if you're in the correct planes over the dorsum in this subpericondylar subperiosteal plane, it doesn't bleed much anyway. So there's no real need to inject there from my point of view.
Yeah, so we should infiltrate between the upper and lateral cartilage on either side on 1 centimeter away from the midline. So there is no chance to distort the anatomy and irregularities. Now the last for the along the margin of for the osteotomy. So I think whenever we do the osteotomy, then we infiltrate, but some surgeons infiltrate on either side of the periosteums, inner side and outer side along the nasofacial groove. I usually infiltrate only outer side of for the osteotomy. And I think whenever you do the osteotomy, so you should wait properly for the 15 minutes for the proper hemostasis. So these are some hemostasis in proper infiltration steps for the rhinoplasty. Now we open the nose.
Can I interrupt, sir? Sunil, this is Lokesh.
Yes, sir.
Hi, Sunil.
Good afternoon, sir.
Yeah, good afternoon.
We are waiting for you.
Yeah, can I ask 2 questions from Sandeep? Sandeep, are you there?
Yes, hi Lokesh, how are you?
Yeah, good. 2 questions, quick.
Go ahead.
Sir, your voice is not clear, na?
Lokesh, I think you're cutting out.
Hello?
Yeah, hi, sorry. I didn't hear the question.
Yeah, so use of beta blockers. Do you tell your anesthetist, do they use it or
no?
Never.
No, not generally. No.
So how do they lower the blood pressure if the blood pressure is high? Because there is always, when you are injecting adrenaline, there is cardiac stimulation, and that jump, and the BP jumps up. So how do you counter that?
If you heard the last bit of what I said previously, the good bit is I concentrate on the surgery and they concentrate. I have an anesthetist who's been with me for 17 years. He he uses a variety of pills and potions. To be honest with you, he's changed things over so many times over the last 17 years that I don't even know what his current formula is. He's never specifically used beta blockers.
Right.
I mean, I can probably forward you what he uses, but normally we have a systolic in the region of about 80, 80 to 90 maximum. Lokesh, the other advantage, of course, for us is we generally have cocaine available in the UK.
Okay.
So that reduces bleeding quite a bit. Although one of the private hospitals I operate in at the moment does not have cocaine available, so we're using cofenalcaine instead, which actually works reasonably well. It's not as good as cocaine, I'll be honest, but it's not bad. I know he uses remifentanil a lot, which controls the blood pressure quite a bit. And,
remifentanil is good.
Remifentanil is his favorite.
Tranexamic acid, like locally,
we give them tranexamic acid as well. So
local or systemic?
I think he gives it systemically.
Okay, you never used it locally?
No, I've never used it locally. No, I've never used it locally. He gives it systemically. So the combination of tranexamic acid, a little bit of cocaine, or at least cofenalcaine, and then the remifentanil. And as I say, most patients, he controls the blood pressure right to about 8. I used to work with one anaesthetist who used to bring the blood pressure down to so low that his blood pressure inversely was proportionate to mine, because it used to go so low that my blood pressure used to go up when I looked at this. And he at one point, he used to just put a little tape over the blood pressure and say, you stop looking at the screen and you concentrate on your operation. But he used to run systolics down to 50, which was always very worrying for me with my patients. But I think anything less than about 80, 90, anything less than 100 systolic, you're doing okay. And of course, controlling the pulse rate as well.
Right. Okay, Sunil, go ahead.
I think the Amar Singh sir also, I think, joined. Yeah. Hello, sir. Welcome.
Thank you, Sunil. You are doing a wonderful job.
Thank you, sir.
Can I add, hi, Dr. Sandeep and Lokesh.
Hey, Amar, how are you?
Yeah,
fine. Thank you. Great to see you all. And regarding this blood pressure business, as well as I think hemostasis part, I think it is not only the drug which anesthetists use. I think it is the level of anesthesia which makes very important factor in the bleeding during surgery. Even if your blood pressure is 80, 75, 80, still patient may bleed, because at times the anesthesia level, if they keep it in superficial plane of the anesthesia, so patient still bleeds, because patient is really half conscious, so it really bleeds. And if the patient, so you have to work with anesthetists, they have to make the patient in the deeper plane of anesthesia in order to make the surgical field bloodless. Secondly, I think your surgical dissection is very important to control the bleeding. If we are not in the surgical plane, that makes a lot of difference in the bleeding as well as post-operative morbidity. Third thing, which I feel that today only I just finished, I coming back from my theater, we finished doing one surgery. We find we have started using this tranexamic acid. And I don't know, this was my initial experience. Surgery was so great, hardly any drop of blood during surgery. So I think I don't have much experience of using myself, but there are a lot of literature available.
So did you locally infiltrate, or did you give it systemic?
No, it is bolus dose. It can be given 2-3. It can be given 3 ways. One is you can give a stat dose, anesthetists give you when you induction. Second thing is you can give an infusion. If anesthetist can help you to give continuous infusion of tranexamic acid. And third is you can give local, just like your adrenaline, you try to pack the nose, you can use during surgery. So during surgery, that can help.
Okay, so
how much is the dose? How much is the dose?
Lokesh, I'm just texting my anesthetist just now to find out what dose he uses. I'll get back to you shortly once he gets back.
Today I used 10 milligram per kg body weight. I gave 500 milligram state dose IV, 500 milligram. So it was, I had a wonderful surgical field during surgery.
Right.
So now we carry on further.
Yeah, sure.
So we use the open approach, and in open approach we use here the for the inverted V incision for the columella incisions and the marginal incisions. So it's my advice to the junior colleagues. Then you always know about the approach. What is the approach? What is the incision? What is the technique? So these different words we use interchangeably. But the incision is a surgically created cut to gain access the underlying surgical framework, and the exposure, like the approach, is a specific type of the anatomical dissections to get expose this inner framework. And the another technique is a particularly type of maneuver to change the structure, like cephalic framing or something. So we use the inverted V incision first. For the inverted V incision, there is different type of the incisions, either inverted V incision, stair-step incisions, or the W incision. That type of the incision is doesn't matter. We always use the incision is in broken line manner. So the aim of the incision in broken line manner, we break the scar and we lengthen the this incision line just to decrease the force of contraction. So we use the inverted V incision on the mid part of the columella. We always on the mid part of the columella, just above the foot plates. And sometimes we use the high columella incision if you want to deproject the nose, or low columella incisions if your case have a binder or something, then we use a low columella incisions here just to increase the columella length. So for the inverted V incision, first we finish this incision, and on either side now once your incision is finished, so for this incision the site is important. The type of the incision is doesn't matter, and your incision is not below the foot plate area, because here we have the one important tip support mechanism. Sorry.
So which approach do you prefer? And Dr. Sunil,
yeah,
which approach do you prefer? Which approach you prefer?
I always prefer open approach, because in open approach we can better learn and everything is exposed. So I usually prefer the open approach. But suppose if a patient have a minor irregularities or minor hump deformity, so definitely you can do by the closed approach also, because there in rhinoplasty surgeries there is no single rule that you follow. That according to the need of the deformity we can go either open or close. But mostly if a patient has the secondary or the revisions or asymmetric tip deformity, in that case the open approach is the best approach. So once your incision is finished, then you just take it. वो देना मेरे को सीजर देना ये दे sure जल्दी लो
बता दो यार हमको अपने लिए
yeah it's okay now ठीक है अब ठीक है. So once your incision is finished, then you just take a sharp scissor from this side to from ipsilateral to the contralateral. Now the important thing, if you feel resistance during this scissor, then don't do the forcefully. You can change and from the another contralateral side. Okay, otherwise you create the false passage. So from this seizure is passed from this to that sides, and then you complete the incision. Once you complete the incision, then you ask the assistant by the just hold this, give me the double loop. So it's a very good technique. Now, after the raising this columella flap, the first structure you identify, this is a very good technique by the sponsor, that you just find this medial crust. Sharp dena yaar. You just find this margin of the medial crust. So this side, look at this side medial crust and this side medial crust. So you have a minimum chance of the injury of the margin of the medial crust. So now once you identify the margin of the medial crust from the both sides, then go further above. Seizure dena, दूसरी curves seizure dena.
No, get him to support the medial crust. That'll help you. Get him to use this skin hook.
Yeah.
On the medial crust.
Yeah, definitely, sir. Now that your 3-point traction technique is very good, one by your index finger and the thumb, and another 2 by the assistant.
Yeah. So the Sunil, put these.
So this, yeah, sir.
You know the skin hook he's got at the bottom. Use that around the corner here.
Yeah.
Pull the medial crust down. You see what I mean? Don't. He's got it down at the bottom there. Use it to help you.
Yeah. The cut is very small. Do the angle seizure dena. Angle seizure dena. Angle seizure dena. वो दे देना angle seizure यार. Give me this one. So this is the angle seizures. So we go and then you can use the marginal incision also first, but I think this is the good approach. First, along the margin of the lateral crust. And your counter traction is important.
Yes, again, Sunil.
Sir.
Yeah.
But get the skin hook into where the soft tissue triangle
exactly,
is.
Where Dr. Yapampon is mentioning. Take this inferior flap where I taken a skin hook, single skin hook.
Yeah, take the single hook. Sunil, listen. Sunil, listen to me.
Yes, sir.
You know where he's got the single hook at the moment. Take that out.
Take out that one.
Take out the single hook. The single hook. Sunil, single.
Single hook.
Single hook.
The inferior flap here.
Yeah. Now put it in the soft tissue triangle area. That's it.
Exactly. Yeah. No need to retract the lower flap. Single hook. Sunil.
Yes, sir.
Take first. No. Wait before that. Take single hook where Dr. Pon is mentioning.
Yeah, I have the single hook on the columella flap.
No. Where soft triangle is there. Single hook, not double hook. Single hook. Single hook.
वो देना डबल वाला देना मेरे को बड़ा
single.
Okay, and then put a single in the soft tissue triangle area.
But I usually comfortable, sir, by this one.
Okay, all right.
Okay.
It'll just help you.
Comfortable. I just first finished my incision. And sir, very important questions. What is your lateral limit of the exposure? Just for what is your opinion for the beginners? What is your lateral limit of the dissections on the medial lateral crust, sir?
I think it depends, Sunil, on two things. Number one, if you're going to be doing any work laterally, for example, if you're going to be doing a lateral crural overlay, then you'll need to expose. If you're going to be transposing the lateral crura, you'll have to expose. But otherwise, you need to go far enough laterally to give yourself exposure to the. So you need to go at least, I say, between half to 2/3 of the way across laterally.
So at least I think that 2/3 should be exposed.
Yeah, I think half. The problem with going halfway is that you won't have enough exposure. But I think if you're doing lots of lateral crural work, particularly lateral crural work, then you have to expose it all.
Yeah. So once our incision, marginal incision is complete, then you start the dissections. You expose first the tip lateral cross on the both sides. So the other important thing, the counter tractions by your index finger is important. So you get the proper hemostasis also, and the plane of the dissection is important after that. So my plane of dissection is the subpericondrial manner. So I lift up. वो देना मैं काकी. I use a very good instrument by the kaki that for after the incision. So it's a very good instrument. It's very good instrument just for expose the cartilage.
So in the midline, you've left behind that bit of tissue. Do you want to talk about what that is?
Yeah.
Yeah.
You talk about this one, yeah.
Yeah. So this is the ligament of the pitangui that connect the both side of the dome with this soft tissue envelope. So Amar Singh sir, can you preserve it frequently? And because some person they preserve this pitangui ligaments.
Oh yes. At times I preserve it, at times I just dissect it off, and later on I try to suture it to supratip area.
Okay. So you suture it again later in the.
Yes. Yes.
You can mark it. You can mark it, Sunil. You can put a little suture. Some people will put a little suture in it, or you mark it with a pen, and it can help close that supratip space, which can help with in the post-op period. So increasingly, I've started marking it. I don't tend to preserve it. I think it impedes my dissection otherwise. So I tend to mark it and then reconstruct it.
Okay. So once your exposure is complete of the tip cartilage, then you expose the mid vault.
So you always prefer subpericondrial dissection, or sometimes you go for suprapericondrial also?
No, I always prefer the subpericondrial dissection. That is the complete avascular plane.
Okay. Now, Sunil, I think I would not agree with you on this point, because in our noses, when there is very soft, thick soft tissue cover,
okay, sir.
It is mostly Western noses where you tend to go subpericondrially. In our noses, we always prefer suprapericondrial for the reason that you may have to do a lot of thinning of the soft tissue from the nose. And if you leave the perichondrium into the soft tissue, you end up throwing the perichondrium.
Yes,
and
sir.
If you stay suprapericondrial, even that is a bloodless plane, because you are deep to the smas layer. So this is what I don't know what others think about it. Dr. Prawn and Dr. Amarson,
you have a long series of rhinoplasty, sir. So in the Indian scenario, I think you prefer the suprapericondrial. That is the better.
Yes. In our type of noses, I think suprapericondrial is much better.
Okay,
yeah,
sir.
I agree with Dr. Lokesh. At the lower lateral cartilage, lateral crura, when you are lifting the soft tissues, I do again suprapericondrial. It's very difficult in our type of patient, thick skin patient, to do subpericondrial at the lower lateral crura and middle crura structure. And at upper lateral cartilage and mid third, upper lateral, again I do suprapericondrial, not subpericondrial. But at the nasal bones, it has to be subperiosteal.
Yeah, agree.
So this is the.
I think everyone's got their own way of doing it. I do subpericondrial. It doesn't matter which skin type we have. I mean, I look after every skin type.
The main problem is that our cartilages are so small, and
no, I get it. I think I get it. I mean, whether you leave subpericondrial, you leave perichondrial layer on the skin flap, or you leave it on the cartilage, I think it's a moot point. I think the main reason, and I think from a learner's point of view, is you want to go into a plane that's as bloodless as possible. So we've talked about the importance of anesthesia, and Lokesh, just while I'm here, I just had a text from my anesthesia colleague. He gives 1 gram of tranexamic acid.
Okay.
And he uses remifentanil plus either a propofol infusion or inhalation anesthesia. So, and he prefers using an LMA, angiogram. But the remifentanil is 1 gram of tranexamic acid. But as Dr. Amar said as well, getting into the correct plane is part of the way. I mean, obviously this patient is bloodless for obvious reasons, but you want to get into the correct plane. So I think from a junior person's point of view, you want to stay as deep as possible. And yes, of course, if you're just treating Indian skin, which tends to be thicker skin, then being subperichondral, supraperichondral, there's probably not much difference in it in terms of bleeding. Although I still think you get less bleeding in the subperichondral plane. But anyway, I'll defer to your vast experience of just doing Indian noses. But about 35-40% of my practice is Indian noses as well. I just get a lot of Indian patients in the UK. So, we do have quite a bit. And I don't tend to differentiate. I just go into one plane, which is the subperichondral, subperiosteal plane. But you're right about the weaker cartilages for sure. And you're right about that soft tissue envelope, and you'll probably get away with it. I think that the two things why you want to go subperichondral is, number one, to reduce the amount of bleeding. And secondly, particularly in the thinner skin nose, you want to leave as much soft tissue on the skin flap as you can to hide irregularities. Because the concern is if you go superficially and you're much more likely to see irregularities and indeed cause irregularities than if you're in the subperichondral plane.
Yeah, in thin skin, there is no dispute in thin skin. Yeah, I agree. Yeah.
So now the exposure, sir, one important thing, what is your lateral limit on the dorsum, sir? Pons, sir, on lateral limit on the dorsum of the mid vault, how much laterally go? This is simple question frequently by the beginner, sir.
So again, I think it really depends on what you're trying to achieve. Now, there is, as you know, a big vogue for doing powered instrumentation, and specifically piezo ultrasonic rhinoplasty surgery. That's become very fashionable, popular in recent times. And for that, if you're going to extend, you want to see your whole osteotomy, then you have to go all the way out laterally, almost doing an extended open approach laterally to be able to see your margins of where your osteotomy is going to be. But I think if you're not going to be doing that, and you're just going to be doing normal osteotomies, again, I'd say between half and 2/3 of the way across the lateral is enough for what you need. Again, it would depend if you've got a very long, thin dorsum where you're going to be taking quite a lot of the hump, bony and cartilaginous. You may want to do a little bit more. If you've got no bony work to do, or particularly if you're going to be just using small grafts, so in an augmentation rhinoplasty, then you want to keep your pocket along the dorsum as tight as possible. You really don't want to extend it laterally. So it depends on the indication, but for most reduction rhinoplasties where you're going to be doing a de-hump of some kind and some osteotomies, I'd say between half and 2/3.
Okay. Yes, sir. So after the exposure, the tip, mid-vault and the dorsums, now we expose the septum. So it's your individual priority that how you approach the septums. For the ENT persons, they frequently do the septum work through the Killian's incisions or the...
Did you elevate the periosteum from the bony dorsum?
Yeah, sir. Okay. Periosteum from the bony dorsum. It's a female patient, so it's very easy.
Okay, right up to radix, isn't it?
So for the approach of the septums, either you use the Killian incision or the hemitransfixation incisions. It's the individual choice. But if you are the more comfortable with the inner side through the Killian's incision and the hemitransfixation incision, you know where you need the which type of the incision. If your septum have the posterior deflection, posterior distortions, anteriorly the caudal septum is the septum, then you can use the Killian incisions at the junction of the vestibular skin and the mucosa. But if your patient have a caudal septal deflections, then in that case, the Killian's incision is not good. So you use just on the margin of the prominent margin of the caudal septum from the top to bottom, that is the hemitransfixation incisions. And if you are more comfortable, then you can do the septal work on that sides. But Dr. Pons sir mentioned that if you already open this, then you can go through this. So it's the individual approach by the separate the medial crust. So after whenever you separate the medial crust, then the first structure you identify the anterior septal angle area. Anterior septal angle area is the angle between the dorsal septum and the caudal part of the septum. So it's my advice, personal advice to junior colleagues, then this step is very crucial step. So sometimes when a patient have a crooked nose, then it's very difficult. So you do very patiently. Sometimes you have the difficult to getting the proper plane, but sharp scissor there. So once you identify the anterior septal angle, then again it's by you can use a scissor in this way, and then you can find the plane. So once you get the plane, then one side, then you separate it, and on the another side you always use the counter traction. Your counter traction is important. So once you getting the plane on the both sides, and you always try to getting the plane on the uppermost part of this, because here the mucoporicondium is the less adherent. Another way, if you use the already the Killian's incision, then another technique by the FODA, that they put a periosteum from these sides and make a hole that's easy for getting this plane. So first you elevate the mucoperichondrium from the septal cartilage, septal cartilage, and then the perpendicular plate posterior inferiorly, and then posterior superiorly, and then in the last from the maxillary crest. Because if you go first from the maxillary crest, then it's very difficult to lift up the periosteum from that place. So you complete expose from the both sides, and once you complete from the both sides deglobing the mucoperichondrium or periosteum, then you can separate the upper lateral and the septum. But the important thing, whenever you separate the upper lateral and the septum, then it's you assure that you separate the mucoperichondrium. Otherwise, the post-operatively you develop the internal nasal wall insufficiency. Knife. So we separate. So now our exposure is complete. After the complete exposure, we just again have a second look for the anatomy. Hold it. I think we cut it. We cut it, the scissor. We cut it, the scissor. Give me the scissor, big scissor. Give me the big scissor. Yeah, give me the scissor. We earlier discussed about the surgical landmark of the nose. Now we have a second look that what underlying anatomy that we earlier discussed. So this is our bony vault. This is our bony vault. This is the nasal bone. And this is the mid vault. This is the upper lateral cartilage. फोकस और करना ना, इसको सही थोड़ा फोकस करना, थोड़ा सा प्रॉपर एक बार, हाँ प्रॉपर करना, यहाँ पे करना है, यहाँ पे, या so this is the nasal bone, this is the upper lateral cartilage, this is the lower lateral cartilage, LR cartilage on the both sides, this is the junction of septum and the upper lateral cartilage. And this is the LR cartilage. So this LR cartilage have the three part. This most medial part, that is the medial crust. And the most lateral part, this most lateral part, this most lateral part, that is the lateral crus. And the part that connect these two part, that is the intermediate or the middle crus. So every part of this LR cartilage have their significance and the importance. This medial crus have the two part. One is this vertical part, that is the pillar of this columella part, and this is the foot plate part. We never enter until unless we have no any deformity this foot plate area, because it's a important one of important tip support mechanism, because the whole tip dynamics is depend on the tip support mechanisms. We have three major tip support mechanism. One is the size, shape and resilience of this entire LR cartilage. Second is the attachment of the caudal septum with this medial crus, and third is the scroll area. So it's a important tip support mechanism or site of the incision that should be always above the foot plate area until unless your pure patient is binder or very short columella. So this is the foot plate of this medial crus, and the this is columella part of the medial crus. So this foot plate is basically rest on the anterior nasal spine's fatty tissues. But sometimes in the advancing age or during the surgery or the due to the infections, this fatty tissue may get reabsorbed, and the consequently this support is lost and the patient develop a droopy tip. So this is the importance of the anatomical knowledge of your, you know, the normal anatomy of this LR cartilage. Now the second part, that is the middle crus or intermediate crus, that have the two part. So this anterior part, that is the lobular part, and this part is the domal part. So the basically the angle of this tip or the definition of the tip is depend on angulation of this domal part, and the length of the infratip lobule of the tip is depend on this entire intermediate crus. Sometimes if a patient have the axis infratip lobule, that it indicate that it have the long intermediate crus. So this is the intermediate crus. Now the widest part of this LR cartilage, the widest part of this LR cartilage, that is the lateral crus. So this lateral crus have the two margin. One is the cephalic margin. This is the cephalic margin. So this cephalic margin of the lateral crus and the lower part of the upper lateral cartilage have the overlapping. This and overlapping in the attachment. That is the scroll area. This one, that is the scroll area. So this is a important tip support mechanism. And this caudal margin of the lateral crus is also important landmark during the marginal incision in open approach. So we always knife dena, wo dena, 15 number blade dena, 15 number blade. If you are not sure that where you get the incision, marginal incision, then you by a handle of knife you can feel this ones, and you can easily feel below this. So this is the site of the lateral marginal incision in the open approach. So we always feel this margin for the, so it's an important landmark for the marginal incision. And now this is the anterior septal angle area. This is the dorsal septum. This is the caudal septum, and this is the this upper lateral cartilage attached with the septum, and laterally this upper during the osteotomy later we see that this laterally we attach with the Webster triangle area. Now after all evaluation of this interior of the anatomy, now after the exposure step for almost for every step deformity is the same, but sometimes if your patient suppose have a saddle nose, and if you want to augmentation of your dorsum, then when you make the dorsal tunnel, then it should be adequate according to the augmentations. If you made a big tunnel, then you need a lot of material for the augmentations. But if you have a crooked nose patient, in crooked nose patients, then your exposure should be complete pony vault, mid vault, and the lower vault. And then you separate this upper lateral and the septum. Because when the patient have a deviated nose, when patient have a deformed nose, then the deformity have some extrinsic and some intrinsic force on the septum, and they ultimately distort the septum and they deviated the septum. So until unless you not separate the upper lateral and the septum in crooked nose, and that case you never correct and you never straightening the septum, because whenever you separate this upper lateral and the septum, that it eliminate the extrinsic force on the septum and it allow the septum in the midline. So in that case, definitely you separate the upper lateral and septum, and it's not necessary that in every case you open the upper lateral and septum. It's depend on the case to case, because in rhinoplasty there is no single technique and there is no single rule that in every case you open the upper lateral septum. But if you have a crooked case, then definitely you open the upper lateral and the septum, because after separation of this attachment, that we eliminate the extrinsic force on the septum and we assess better axis part of the dorsal septums, and we have the better exposure after the separations. So now after the separations, for the septal reconstructions, we harvest if we need only graft, and if we reconstruct if our septum is deviated. If our septum is deviated, then we excise the deviated part of the septum, because when you excise the most deviated part of the septum, that it also eliminates the intrinsic force itself on the septum, that is allow in the midline. Dr. Pond sir, can you agree me that not in every case there is no need to separate the upper lateral and the septum, sir?
Again, depends on what you're doing. But if you, as you know, my favorite way of taking a hump down is to deconstruct the upper lateral from the septum and then
Yes,
take it sequentially.
Yes,
so
sir.
that so that you take your upper lateral cartilage off the septum, and then you reduce your dorsal septum down first. And you've got the option then of leaving your upper lateral cartilages long. And if you're particularly in a patient where you don't have much cartilage, you can use spreader flaps instead of taking that down. So if I'm doing that sort of dehumping, then yes, I prefer to do it separately.
Yes, sir. And after the complete degloving from the both sides, then you assess your septum. If your septum have the dorsal septum is excess, then you assess the septum. If your dorsal patient have hump nose, then we first excise the hump, and then later we harvest the septal cartilage. So for harvesting the septal cartilage or for the dorsal support and the caudal support, we should preserve at least 1 centimeter on the dorsum, 1 centimeter on the dorsum, and 1 centimeter on the caudal part. And another important thing, when you turn it, then it should be curvilinear and not straight. So for getting the support of the caudal part of the tip. So you can harvest or you can do the septal work complete through this open approach by the separation of the medial crus, or through the Killian incisions or the hemitransfixation incision. This is the Storz periosteum. So one end of this is very good. So you can separate the septum from the perpendicular plate easily. You can use the Bellinger knife also, but it's a very good instrument. And I always advise that in the beginning, you should purchase the good instrument, either the Medicon or Storz. Usually we see that when we start out either rhinoplasty career, then some cheap instrument, and then we think then later when we become a good rhinoplasty surgeon, then we bought the costly instrument. But I think we should have a very good instrument in the beginnings. So this is over the septum, and this is the dorsum part of the septum, and this is the caudal part of the septums. Now, after the harvesting the septums, after the removal of the septums, we can assess the dorsal part and the caudal part. If if our caudal patient have suppose caudal dislocations and the caudal part of the septum is dislocated and the patient have the tip deviations, then first you complete free this caudal part of the septum from the maxillary crest area, and then once you free it, then you again fix it and relocate in the midline. So for the fixing in the midline, there is different techniques. Some people use the burr hole in the antenasal spines, and there is different technique, but it's a very good technique by the Dr. Pon, that like the 40 PDS. Then you just separate this both medial crust by the double hook and give me the. So in this way, you can put a big double hook and then expose. Hold it, hold it. So suppose your septum is tooth forceps. Once you free your septum from the attachment, and then once you free it, and now if your septum is overlong, if suppose your patient complaint of the overlong, you have a over projected nose and you're overlong, then you can trim this part of the septums. If you have overlong septums, then you fix it. If the septum is not midline, how you fix it is very simple, and it's a very good method. You can fix it by the perichondrium, periosteum. So you can use this 40 PDS in the midline, in front of, above the antenasal spines, and from one side of the septum to pass from this side to this, and you suture in midline with the antenasal spine. You can use a burr hole in the antenasal spine also, but I think for the beginners, it's the easy. If you adopt the easy method, that is the good. So you can fix the septum in the midline. So you can fix the septum in the midline. And now first you do the septal work, and now you decide that either now you do the bony work or the tip work. Sir, I have a question that what is your work for the sequence? First you do the tip work, or first you do the bony work, osteotomy, or other bony work? Hello. Yes, sir.
Again, it varies a little bit on what you're doing, but as a general rule, I like to do the bony work first and then do the tip work afterwards. It can vary a little bit. Sometimes you have to do the tip work to get an idea of where your tip is going to be before you start taking the dorsum down. But my personal preference is I do the bony work. So I'll do any rasping, dehumping, osteotomies first. Then I tackle the mid-third because it's easier. For example, if you're going to put spreader grafts on, if you haven't got your tip already fixed in the correct, you bring the lateral cartilages out of the way to put your spreader grafts and everything in, and then I do the tip at the end. But it varies. I think some people like to do the tip work, fine tip work first before there's bleeding. For example, with osteotomies, I just find it's in the way I think about rhinoplasty surgery, it's easier that way. But I'm sure Dr. Lokesh and Aman may do it different ways. I don't know. I think it's a personal preference, but I like doing the tip right at the end.
Yes,
yeah,
sir.
So I think Sandeep, I think I do follow same thing what you are doing. I think in most of the depend upon the indication what case you are doing, and also depends upon whether you're doing closed technique or open approach. If you're doing open approach, definitely yes, your bony work, you finish your bony work, do osteotomy, and tip comes at the last.
Yes, sir.
So that you can adjust the height of tip, projection, or whatever you want to do, depending upon what dorsal height.
But sir, I personally feel that if we do the first tip work, then all tip sutures, and then later if we do the osteotomy, that comparative there is a work. So the sutures are every sutures are some disturbed.
And not only that, there is a science behind why you have to do the bony work and osteotomy before, and there is a definite rationale. Not just because my or Dr. Sandeep prefer. There is a rationale for that, doing that one.
Yes, sir.
And because you're mobilizing the lateral bony wall and you have already fixed the tip, how can you then reduce the height of the dorsum? Because with the osteotomy, you are mobilizing the lateral bony wall medially and you are increasing the bony height. How you reduce again?
Yeah. Yes, sir.
So what I just wanted to say, the concept of rhinoplasty, what was in initial 80s, 90s was that you do the first tip work, then do the dorsum. You try to achieve the tip projection, then accordingly you try to get the dorsal height accordingly. But concept has now changed with the open approach. You first achieve your dorsal height you want to achieve. Tip, you can project it, you can deproject it, rotate it, whatever you can do it.
And sir,
how much should be the last one if you are doing open approach? Yes.
How much septum you recommend for the door in the L strut? How much septum is the more than 1 centimeter, or is the 1 centimeter is adequate, sir?
No, I think depends upon your type of the patient. If it allows you to preserve edge as much as possible, up to 1.5 centimeter, both caudal and dorsal strut, that should be fine. Depends upon your indication. If you are you don't need much of graft, then just try to remove what is necessary. Try to preserve the cartilage. You never know, the next time you might have to do the patient again. Then you have the septum cartilage available there.
Yes, sir.
Yeah, but so don't preserve. I mean, don't sacrifice the functional aspect. That's what I want.
Yeah, to say. Exactly, sir. Totally agree with you, sir.
Yeah.
Once you finish your septal work, then you just put a culting suture from one side to another side, from the top to bottom. So just for proper approximation of this mucosa, and just decrease the dead space, so you have the less chance of the septal hematoma, or you can obviate the need of the packing of the post-operative notch. Because until unless, suppose if you have some turbinate work, then you can do the packing Marosil on both sides, because the patient little bit difficult for the patient for the 24 hours the packing in the notch. So this is a very good options. Then you can put the culting suture from one side to the another side, so you have the less chance of the hematoma formation or collection between the septum, and it's very easy for application. Cut it. So now, after the septal work, once you fix your septum, then we do the bony work. So in the bony work, for the bony work, if you have any abnormality after the assessment, if you have any abnormality in the bony wall, and then if you need the osteotomy, then the concept of the osteotomy, the first thing that what is osteotomy? So the osteotomy, especially for my junior colleagues, osteotomy is basically a control fracture of the nasal bone adjacent this ascending process of the maxilla. So it's a basically control type of the fracture just to correct this asymmetrical bony vault. Now, really, the osteotomy is the least controllable but the most traumatic procedure. The reason behind, because this is the procedure when we do, while we performing, we cannot see. So really, especially in the beginning, for my junior colleagues, they always they ask that either the lateral osteotomy is the good and the medial osteotomy is good, or the external internal, because we cannot see that it's very difficult or challenging. So for simplifying the osteotomy, the concept of the bony vault, the morphology of the bony vault, first you should understand. And the second important thing, you analyze, then either you need or not the osteotomy. And the third important thing, the knowledge of osteotomes by which you do the osteotomy, that or for which osteotomy you need which type of the osteotome, how you handle your osteotome, how you care your osteotome. So knowledge of the osteotome is also important. So first, the morphology of the bony vault is important. If we go the anatomy of this nasal bone, then this nasal bone, वो देना मेरे को 15 number देना. We just expose this nasal bone first to forceps. So we expose this nasal bone first for understanding the anatomy. Periosteum. This one. तो इसको यहाँ फोकस कर दे, आ रहा है ना उसमें से. So this bony vault consists by a pair of nasal bone in the central, and on superior lateral the lacrimal bone, it attaches with the lacrimal bone, and the inferior lateral complete this attached with the ascending process of, this is the ascending process of maxilla, and on the superiorly it attached with the nasal process of the frontal bone, and inferiorly it attached in the lower part with this upper lateral cartilage, and this attachment is a very useful. And if you look at the attachment of this with this upper lateral, this a systemic manner in central keystone area, this attachment, this distal part of the nasal bone overlap the cephalic part of this upper lateral cartilage. So these are the important attachment of this nasal bone. Now for this nasal bone, the important thing, one is the shape of the nasal bone, and another important thing, that is the length of the nasal bone, and third important thing, the thickness of the nasal bone. So if you evaluate by these 3 points, then you can simplify the osteotomy. The shape of the nasal bone is just like a hourglass, because in frontonasal suture area, this nasal bone is the widest in this area, around the 14 millimeter. But in the nasofrontal, in this nasion area, in the nasofrontal area, it is the narrowest, and then later it again widen it. So just like hourglass shapes, so it gives on the dorsum the dorsal aesthetic line. So due to the shape of this nasal bone, we get the dorsal aesthetic line that indicate the contour irregularity of the bony vault. If your dorsal aesthetic line have the acute, then it indicate either your patient have over wide bony dorsum or pinching of the mid vault. So the shape of the nasal bone is important. Another important thing, the length of the nasal bone. The ideal length of the nasal bone is 2.5 centimeters. But sometimes if the patient have the like the nasal bone is short, then obviously then the upper lateral cartilage is long. So in that case, if you do the osteotomy, then what happened? This nasal bone fragmented, and this part this upper lateral part inferiormedially collapsed. So patient developed the inverted V deformity. So that is the inverted V deformity. So because the length of the nasal bone is great variability, sometimes the short, sometimes is the long. And another important thing is the thickness of the nasal bone. If you analyze, then the thickness of the nasal bone in the frontonasal suture area is around the 7 millimeter. That is the thickest. And if you go down from the top to bottom, then it gradually taper it. So this part of the nasal bone act as a cantilever, and it gives maximum and whole support from the entire nose. So during the osteotomy, you never enter in this thick part. Otherwise, we create the deformity. So this is the importance. And another, the width of the nasal bone. The width of the nasal bone, there is two width. One is the bony base width and one is the dorsum width. Nasal bone dorsum width. So bony base width, that is the width between this ascending process of the maxilla. And one is the dorsum width, that is the nasal bone width. So you assess properly for simplifying the osteotomy. Now, there are different type of the osteotomy, and it's no need to if you remember according to the locations, if you deal with the lateral most part of the nasal bone, that is the lateral osteotomy. And if you deal with the medial part of the nasal bone, that is the median osteotomy. And if you do the part between the topmost from the medial and the lateral between, that is the intermediate osteotomy. And if you deal with the uppermost transverse part, that is the transverse osteotomy. So these are the different type of the osteotomy: lateral osteotomy, median osteotomy, transverse osteotomy, and the intermediate osteotomy. But the all osteotomy, the goal of these all osteotomy is the similar, that we reposition this nasal bone, but while maintain the stability of the bone. We never unstable the bone. The goal of the all osteotomy is the same. This asymmetrical nasal vault we make symmetrical by these different type of the osteotomies, but when we reposition the nasal bone, but maintain the stability, maintain the dorsal aesthetic line for good aesthetic pleasing condition. Now, first is the lateral osteotomy, because we frequently use this osteotomy, that is the lateral osteotomy. So for the lateral osteotomy, we have the two approach. Either you do from the outside, that is the external approach, or if you do from the inside, that is the internal approach. So first we do the internal approach. The internal approach is the continuous approach, and the external approach is percutaneous multiple perforating approach. So first we learn the internal osteotomy, internal continuous osteotomy. So for this we use osteotomy dena dono. For the internal osteotomy, we use this 3 millimeter Medicon osteotome. The osteotome, one is the straight osteotome, another is the curved osteotome, and one osteotome is the guarded osteotome, one osteotome is the unguarded osteotome. It's the surgeon individual preference, never rigid. But according to the text, if you use the guarded instrument, if you use the guarded osteotome, then this is the guarding end of the osteotome. So when you use the guarded osteotome, then it's the easy where you are working, because you can palpate the guarding end of the osteotome by your index finger or by your thumb. But when you use the guarded osteotome, then it create the more trauma. So consequently, the patient develop more edema later. But on the other hand, if you use the unguarded osteotome, that osteotome have the less trauma and less post-operatively bruising or edema. But it's again your individual choice which osteotome by which you are working and you are the more comfortable. So this is the curved osteotome, and this is the left side. This is the right side, and another is the Udena. So in both these osteotome, especially my junior colleagues, when we hold this one, then the outer side, this is the guarding end is on the outer side. Okay, this is the left side, this is the right side. And by this guarding end of the osteotome, once you finish your osteotome, then you rotate it. On the right side, you rotate it like in clockwise manner. Just getting for the more medial movement of your osteomized segment. And on the left side, you rotate it medially in anti-clockwise manner for getting the more medial movement. So when we do the internal continuous osteotome, then the direction of the osteotome is important.
We seem to have lost the video. I can't see it. Is anyone trying to fix this?
Yeah, video is gone. Yeah.
Okay.
Sir, which Dr. Lokesh, sir?
Yes.
Which pattern, either you like the low to low or the high low high, which according to you, which pattern is frequently you use, sir?
It again depends on the case, and most of the about 80% cases you can either do low to high, or low, high, low, and high. That is a curved osteotomy. That is, sir. In most cases I do that. But in some cases, low to low osteotomy if the nasal bone is short. Yeah.
Okay, sir. So initially when osteotomy is discovered, then this is the path of the osteotome from the lowermost end of the piriform aperture to the nasofacial junction in the till the level of the nasofrontal suture. So this is the low to low, but there is two words. One is the low and one is the high. High, that means towards the dorsum, and low, that means towards the maxilla. So once some new procedure is start, then the pro and cons of the procedure is later we evaluate. So the Webster evaluate that in this pattern, the patient have the problem. Patient have the two problem. One, when we have or engage or the osteotome at the lowermost part of the piriform aperture,
Again, lost the video. We lost the video, Sunil.
Is anyone from the organizer there, Digital Infomedia? Could you check what's going on?
Yeah, the video is not there.
Yeah, now is okay.
Yes, yes.
So in the low to low pattern, when we engage this osteotome, then this pattern have the more chance of the injure the Webster triangle area. The Webster triangle area is the lowermost attachment of the lateral most part of the upper lateral cartilage. So what happened? Once this part of the wedge of the bone, that lowermost part is the damage, then this upper lateral cartilage is medialized. And because there is one more important attachment, the head of the inferior turbinate is also attached, this one. So this both structure is medialized, and the consequently the patient develop the breathing difficulty later. So he realized then if we go little bit higher, then we can prevent this attachment head of the inferior turbinate and the lateral most part of the upper lateral cartilage. So we can prevent the post-operatively breathing problems. And another, if we go in the topmost, if we change our osteotome directions rather than go from this, if we change the directions towards the high, then we can prevent the injury, this nasofrontal toughest part, because already we discussed that this is the very thickest part of the nasal bone. So if we go from this straight in thickest part of the nasal bone, then this part is the part is the free, that is the rocker deformity. So we can prevent the rocker deformity. So the standard pattern of the osteotomy, Dr. Lokesh tell that this is the high, low, high. That means the high, that means the low, and then again high. This is the standard. But again, in the rhinoplasty, there is no single technique by which you can correct the deformity according to the deformity of the case. Suppose if your patient have a over wide bony base, and if you do the high, low, high, then in that case, the patient develop a step here post-operatively. That is the step deformity. So analysis, either is the patient have the over wide bony base or the nasal bone widening. If so, according to the need, we change the pattern of the osteotomy. So for the lateral osteotomy, through the internal approach, we can make a incision first. And it's little bit confusing for my junior colleagues. So it's very simple. First, you identify your anterior end of the inferior turbinate. And after the infiltrations, after the waiting for the 15 minutes, and then you make a horizontal incision just above the head of inferior turbinate, 3 millimeter horizontal, not like this. This is the horizontal 3 millimeter incisions, okay, on both sides. And once you make the incision, then you just select the right or left according to the site, the osteotome. Okay, and then once you select the osteotome, then you engage the osteotome. This is the very important step. You engage the osteotome. The guarding end of this osteotome is not like this. The guarding of the osteotome, that is outside, it is this lowermost part of the piriform aperture. Now, the second most important thing, Your osteotomy is not like this, or osteotomy osteotome is like this. Dr. Pon always mentioned that your osteotome is almost 70-degree angle, and once you confirm it and you hold like this, then you ask your assistant that you use the 2-tap technique, like the tap 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 tap, not continuously, 2-tap technique. So now my osteotome is engaged, and my this thumb, I feel this one, by guarding, and I feel outsides, and now tap 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 tap, and stop. So continuously you go down from top to the light according to the tap 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 tap, and continuously your by your thumb you feel the guarding end. Okay, so you can judge where you are working, because this is the one of the commonest problem in osteotomy, because while we are performing, this is the procedure we cannot see. So this is the big problem in the osteotomy. Tap 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 tap. Now look, now I open my nose. So where I am working, you hold this one. We expose it properly, and then where I am working. So this is my osteotome. So I am not in nasal bone. I am in the ascending process of maxilla. So especially more my junior colleagues and the beginners of the rhinoplasty surgeons, then the lateral osteotomy is not through the nasal bone. This is the nasal bone. This is a female patient, so very short nasal bone. And your osteotomy is through the ascending process of the maxilla. High, low, and then now tap, tap. So you look that, you appreciate my osteotome. Now stop. Now, after once your osteotomy is just on the flat, then you can change your direction of hand like this. Tap, tap. Tap, tap. So you can appreciate my osteotome. So once you reach at the level of the medial canthus is the upper limit of the osteotomy. Never go above the medial canthus. Now there is two ways. Either if you want to do the transverse osteotomy, then you can remove this one. Either you can change in this manner. Tap, 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 tap. Look that. Tap, 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 tap. So this is my osteotome. Tap, 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 tap. So once your osteotome is hit in the thick bone, then the voice is changed. Now, once you reach at this level, then you rotate your osteotome on right side in clockwise manner. Look that. So your nasal bone is shift in the medially. Sometimes, suppose your nasal bone, this pathway is wrong, or your completely in this outside, then you again do it. So this is the way by which you can the lateral osteotomy through the internal route. Okay, so in internal route, the patient develop the more swelling post-operatively, because in the continuous manner we injured the more periosteum layer. So this is the external, this is the internal method of the osteotomy. Okay, now on another side we see the external methods of the osteotomy. Now either you do the medial osteotomy or the lateral osteotomy, it's not a big issue. But if your patient have a asymmetrical nasal bone, like if your patient have a asymmetrical bony vault, that means if your patient have a one side nasal bone is longer than one side is other, one side is small, or suppose your patient have a one side concave nasal bone and other have the convex nasal bone. In that case, the sequence of the osteotomy is important. Otherwise, you cannot correct your asymmetric bony vault. So if your patient have a over wide and asymmetric bony vault, in that case, either you can do first the median or lateral, it doesn't matter. But the intermediate osteotomy is the before to the lateral osteotomy. First do the intermediate osteotomy. Because if you do first the lateral osteotomy, then this your complete free, then how can you do the intermediate osteotomy? So if your patient have a asymmetrical nasal bone, either convex or concave, then you do the intermediate osteotomy first. And the second important thing, now site of the osteotomy is also important. Dr. Pond also always they taught that if your patient have a convex or concave side, then first you do the concave side osteotomy. Why? Because first you do the concave side osteotomy, then this nasal bone is free and it allow the another side of the convex nasal bone to come in the midline. So always first you do the concave side first and then convex side. So it's a very important thing just for learning my junior colleagues. Otherwise, just correction of a crooked nose straightening is a very frustrating job. Till the a lot of times the patient create the nuisance, because if we not correct the sequence of the osteotomy and the site of the osteotomy, so always remember then intermediate osteotomy do first, and the concave side, that means on the deviated side, to opposite to the deviated side, you first do the osteotomy, lateral osteotomy.
Sunil, then, great work. You know, Sunil, I have to leave, so excuse me. I have to go somewhere. So great work. Continue. Okay.
Thank you, sir. Thank you.
Thank you, Sunil. Bye. Bye.
Now, on another side, we do the external osteotomy. So before to the external osteotomy, I think by marking we learn about the intermediate osteotomy, and the every osteotomy have their indications. So it's not necessary that in every case you do the all types of the osteotomy. That's why the pre-operative analysis is the foundation for a successful rhinoplasty. So the pre-operative analysis, you analyze your bony vault, you judge your bony vault, which type of the osteotomy you need. Suppose if you need the intermediate osteotomy, then it's my personal advice to my junior colleagues, then you develop the marking habits externally the nose. So by the marking habits, you identify that what underlying structure have the deformity. And once you open the nose, then you again have a second look. So you develop the impression pre-operatively, then how can you correct this deformity, and which part, anatomical part of the nose have you anatomical deformity. So the marking habit of the nose is good. So for the marking, this is the so we mark on the left sides for the intermediate osteotomy. So for the marking of the intermediate osteotomy and the external osteotomy, we mark in the nasofacial groove, in the nasofacial groove, and between the top and in the bottom in the mid part. So when we do the intermediate osteotomy, the indication of the intermediate osteotomy, that suppose if your one side nasal bone is longer than other, and if your one side nasal bone is convex and the other side of the nasal bone is concave, that is the indication of the intermediate osteotomy. Otherwise, there is no need of the intermediate osteotomy unnecessary in every case. So when you mark between the mid part from the top to bottom, then you use for the intermediate osteotome, that is the 2 millimeter osteotome, mediconval osteotome. So suppose this is the nasal bone, then this is the lowermost part. That means you are in the nasofacial. This is the nasofacial groove. So if you do the external osteotomy, then you mark this nasofacial, and another is the mid part of this nasofacial. Suppose this is the mid part, then we do here for the intermediate osteotomy. So if you check it, then look at, so this is the way, mark pen de. This is the way for the intermediate osteotomy. Mark kar dena. This is the way for the intermediate osteotomy. Okay, and this lateral most part, this part is the for the lateral osteotomy. This part is the lateral osteotomy. So if you do the from the externally, then अब मेरे को इधर आना पड़ेगा थोड़ा सा यार. इससे आ सकते हैं? So for the lateral osteotomy through the external approach, we use the perforating technique, multiple perforating technique, like in stamp perforating, stamp postage manner. If you know in the stamp post in the multiple manner, so in the stamp postage manner, and we use this 2 mm Medicon osteotome for external osteotomy. We always use the 2 mm osteotome. This one, it's a very good Medicon company osteotome. So incision, you make a incision in the nasofacial groove. You make this incision, and if you open it, that my knife is this one my knife. Okay, and then we engage this osteotome again in at 70-degree angle, and then we hold it and then tap. Now look that my osteotome is now inside. Again tap. So tap from top to bottom till the end of the piriform aperture, and between the two perforation, I think the 2 mm normal bone, and then once 2 or for more 5 around perforations, then you can do the green stick fracture just for the medialize. So this is the external route of the lateral osteotomy. मेरे को इससे medial osteotomy करना है. Either you use the external or the internal. Sometimes my junior colleagues, they were very biased and confusing that which osteotomy is better, either the external, the internal. But it's my advice, then either you use the external or the internal. It doesn't matter. The matter, finally you correct the patient deformity. First thing. Second thing, how you are the more comfortable. That is the most important thing. And the last important thing, how your bosses are doing. That is the most comfortable. So how you are training, you are doing. So either you can do the external or internal lateral osteotomy. But according to the theoretical aspect, the external osteotomy is more precise and less injury. But only we have one disadvantage of the scar. But in 2 mm, hardly after the 15 days, until the patient doesn't have a hypertrophic scar tendency, doesn't have the any scar. In my last 6-7 year rhinoplasty career, I doesn't see in any patient there is a scar. So this external osteotomy is more precise, but the internal osteotomy is technically more demanding and have the more injury and the more post-operatively due to the damage of the periosteal layer. So more chance of the edema. So it's not necessary then you rigid or you bind for the thing. Earlier when I start my rhinoplasty career, then I use only internal osteotomy. But I learned a lot of things from my mentor, Dr. Pon, that not in every case only single technique. Sometimes one side you do the internal, but on the other end is the external route. So this is the lateral osteotomy. Now the medial osteotomy. The medial osteotomy, there are sometimes my junior colleagues, they are biased with what is the median osteotomy, what is the medial osteotomy, what is the paramedian, because different book have the different text. So the important thing, the never confuse, never bias the median osteotomy. The goal of the median osteotomy, just we separate the nasal bone and the septum. Just we separate this. This is the nasal bone and between this septum. So the goal of the median osteotomy, just we separate this nasal bone. And indication of the median osteotomy, that when we have a over wide bony dorsums and the deviated bony dorsum, and sometimes when we patient have a crooked nose, then we use the median osteotomy. So how you do the, we use this the 3 mm osteotome, 4 mm osteotome, and we engage this osteotome between just lateral to the in rhinion, between the nasal bone and the septum in parasagittal manner, 1 millimeter lateral. So it's a, ideally it's a paramedian osteotomy. You can say it's the median osteotomy. But what is the median or medial osteotomy? When you put exactly between the nasal bone, then is the medial osteotomy. Then you just like a open book, you separate the nasal bone. But ideally, practically, we always do the paramedian osteotomy. So we engage this osteotome between the nasal bone and the septum, and again you feel it, this osteotomy part below the skin, and you use the again 2-tap technique, like the tap tap, dire, 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 tap tap, tap tap. Okay, now again you have the two manner for the median osteotomy. Either you can go straight in the paramedian manner, or either in the superior oblique manner. Okay, if you want to go in the superior oblique manner, in that case there is no need to the separate this part, transverse part, and no need to the transverse osteotomy. But if you go from the paramedian, just go the straight, then in that case you need the transverse osteotomy. So now look that I separate my nasal bone from this bony septum. Again, like on the other side, tap tap, tap tap, tap tap, tap tap, tap tap. So again on the another side. So this is my bony septum. This is my bony septum. So this is the median osteotomy. And in case after the lateral osteotomy, intermediate osteotomy, and the median osteotomy, if your patient have a gross deviation, the root of this nasal bone, then you do the transverse osteotomy. Then you do the transverse osteotomy, same in the perforating manner like the external osteotomy. Give me, you know, but the important thing for the transverse osteotomy, when you do the transverse osteotomy, then you do always below the nasion, never above the nasion. Tap tap, 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 tap tap. So when you want to straight this and you want to the separate this part, the root of the nose, then we need the transverse osteotomy. So this is the different type of the osteotomy. Dr. Pon, sir. Hello.
Hi.
Sir, that is the right that usually when you need the transverse osteotomy.
Yeah. What about it? Sorry.
Yeah.
Sorry, what was the question?
Yeah, one important thing, how frequently you need the transverse osteotomy?
It's pretty rare, to be honest. I very rarely use it. It's really only when you have bones which are asymmetrical. So in patients with significant deviations, and it has to be a significant deviation.
Yeah.
i.e. when one bone is significantly longer than the other bone, then you need a transverse osteotomy to essentially make the bones symmetrical in length. But I don't use it that often. I mean, you can use it for, as you mentioned, for very wide set nasal bones. You can do osteotomies on both sides. Or in very curved bones. I mean, you can use that, although, again, powered instrumentation works very well. So I tend to use piezo for just a little bit of bony sculpture instead. There's not a huge indication to do intermediate osteotomies, but I think the main indication is really when you've got
main indication is like the deviated
asymmetrical nasal bones.
root of deviated root. And another one important thing, it's very, very frustrating that sometimes if your patient have a crooked nose and so bad crooked nose, in that case, when you do the osteotomy, median osteotomy, and then so many times, then the keystone area is disrupted and the whole septum is fall down. And it's a common problem, especially sometimes in my fellowship course, my junior friends, they ask then in that, how can you prevent that? Because once the keystone area is disrupted and the septum is completely fall down, because in the crooked nose case, the septum is already distorted, and in that case, and it's very problem. So how can you prevent? It's a very good technique by the Dr. Pon. Then when you engage like this, your medial osteotome, then rather than you can do, you have another way. What that another way? By you can engage transnasally, transvestibule your medial osteotome just above the keystone area. Like, so you can prevent the injury of this keystone area. Like then, if you can see in this case, you can enter your osteotome in this way, just more than just above the keystone area. So you can do the median osteotomy also. So be cautious, especially in crooked nose cases, because once this septum is fall down from the keystone area, then it's very difficult to reconstruct it. And suppose this keystone area is disrupted and your septum is fall down, then what will you do? You never bias. Then you can reconstruct it. How you reconstruct it? You just get a needle. You just get a big needle, and then you just pass from the one side, from the one side to this side, from the one side to this side, through and through. Okay, from this side to this side, through and through, and then pass a needle in the wide bore needle, and you just pull it, and then yes, one suture on in this sides and one suture on this side, and you tie this one. And there is a needle, Sebastian needle is also available for fixing this disrupted. So the prevention is the better. So you can prevent and you have the precautions, especially in the crooked nose, for maintain the integrity of this keystone area. Now we see the keystone area. Just मेरे को देखो देना एक बार. If we separate this, look that for better understanding tooth forceps. This is the attachment. This is the attachment. So you never confuse that this upper lateral cartilage is this not over the nasal bone. This always, this upper lateral is not below this one, and this is the nasal bone. Look that. So this is my nasal bone. This is my nasal bone, and this is my upper lateral. And this overlapping is around the 9 millimeter in the central keystone area. Because we can divide the keystone area. One is central keystone area and another is the peripheral keystone area. So in peripheral keystone area, this overlapping is gradually decreased. That's why this keystone, central keystone area is the main area where this upper lateral cartilage get maximum support. And really, this upper lateral cartilage is a subserving cartilage, and it's very important cartilage because it acts as a bridge between the upper vault and the lower vault. Through the keystone area, through the scroll area, through the internasal wall area, and through the Webster triangle area. So it's a very, we always maintain all these attachments during the rhinoplasty. Otherwise, you create a iatrogenic deformity. Now, once suppose we finish the this septum area, then how we restore the septal support and how we restore the mid wall support. Suppose if a patient have a crooked nose, then when we have a distort and the deviated this upper lateral cartilage, then there is a different manner to reconstruct it. We use the spreader graft, we use the spreader flap, and we use the flaring sutures. So in this case, we just demonstrate the spreader graft. So first you learn.
Sunil.
Yes.
Sunil, it's almost 12 o'clock here. I have to pick up my daughter, so I'm going to have to leave. I'm afraid it's been over the 2 hours. So can I just say what an excellent demonstration you've given? It's really lovely to see how your own skills and your ability to teach has improved so much over the last few years, and been a pleasure to be part of that. And well done. It's excellent. I mean, everything you say, it's great. It's nice to hear my words coming out of your mouth, and so it's a very, very good, excellent demonstration. And I'm sorry I have to go, but I'm going to have to pick her up just now. So we'll catch up soon. And for those who are watching, do listen very carefully to what Sunil is saying. He's giving really an excellent demonstration, and hopefully we will be running the fellowship course again in Jaipur later in the year.
Yes, sir. We're also waiting. Thank you, sir.
Thank you. Okay. Thank you very much.
Thank you very much, sir.
Thank you.
Yeah. So we demonstrate the spreader graft. So first, the important thing that what is the spreader graft? Why we need the spreader graft? So we use the spreader graft for the reconstruction of the mid vault. There is a different indication of the spreader graft. Whenever we separate the upper lateral and septum, there is no need to use the spreader graft. We have a certain indication because in Indian patient have a thick skins and we have a very good dorsum support. So no need in every case, especially just this thing, remember my junior friends, then there is an indication. You keep them in your mind that what is the indication of the spreader graft. The indication of the spreader graft, whenever your mid vault, the dorsum is deviated. Your dorsum is deviated and you have the inverted V deformity, or suppose you have the open roof deformity. That means when you remove your dorsum more than a half centimeter, more than 5 millimeter, then you use the spreader graft and just to maintain the dorsal aesthetic line. So in that case, you use the spreader graft because by this small piece of the cartilage, and the septal cartilage is the ideal source for the spreader graft. And the ideal length of the spreader graft is around 20 to 30 millimeter long or 3 millimeter width. Now, either you use the both sides or the unilateral sides. It depend on the indications. In rhinoplasty, there is not a single rule that every times in every case you use on both sides this spreader graft. So according to the patient need, so this is my spreader graft. So after making the ideal shape, you can measure it. So according to the need, suppose if your caudal septum is short, and if you want to the lengthening of your nose, then you can lengthen your nose by the extended spreader graft. Otherwise, the spreader graft we placed between the mucoperiosteal pocket between the septum and the upper lateral cartilage. Why we call the spreader graft? Because this small piece of the cartilage that spread this upper lateral laterally, and it create the cross sectional area of the internal nasal valve area. So that's why we call it the spreader graft. And ideally length, I already told that around 20 to 30 millimeter long and 3 millimeter width. And the top end, upper end, you should upper end taper like this. You cut it this likely because we put it inside the nasal bone. So we cut it like in this manner. Now, after the making the ideal shape, next important thing, we place it in the mucopericondial pocket. And I think you also, because it's a little bit tricky job, so you also just trained your assistant, so he also help you properly. So you place it like this one. This end we insert below the nasal bone. Okay, not like this one. We put it like this. So we put it like this, and the another, you make a slot on the spreader like this. That it's very easy to place on both sides. Then on another side you fix it. So you have the advantage. Suppose if you put it directly, then it fall down again and again. So these are the so many short tips that you can simplifying the rhinoplasty. Now, once you place it in the mucopericondial pocket, and it's a very important thing before to put the spreader graft, and you just separate this mucopericondial completely till the top end of the dorsal septum. So once you put it, then now the two way to fix it. First, either you fix this three structure by a needle like in this manner. This is the one way. Sometimes your dorsum septum is in crooked case is very distorted, and it sometimes it's calcified. In that case, it's very difficulty. So now you can fix one more needle. Give me one more needle. You can fix by one more needle, like directly from these all 5 structures. The first from the upper lateral cartilage, and then again in this spreader, then again in another side spreader, and again in so this is the another way. So but first needle, I think is better for the junior colleagues. If you fix these 3 structure when you put the spreader, then easy for you. Then another second needle that pass from one side to the contralateral side in all 5 structures. Now, another important thing, now how you fix it. So for the fixation of this spreader, I use usually the 40 PDS suture, because the 40 PDS have the better strength and the needle is long. Bad luck in India, we don't have the straight needle. If you have the straight needle, then it's very easy to fix it. Now again, you have the 2 way to fixation of the spreader graft. Either first cartilage holding. Always you never use for the cartilage holding this Takahashi forceps. You always use this cartilage holding forceps because he have a lot of serrations. So it hold firmly. Whenever you put like the dome sutures and fixation of the spreader graft, and you hold your cartilage in this way. So you hold like, and then first you fix, I think, the 3 structure from one side to the another side. So first you complete pull your thread, because if you pull your thread after the needle goes on that side, then it's very difficult and he distort the whole assembly. Now again you hold it. You do it very patiently because this work is little bit tricky, and sometimes the assemblies fall down. But be sure that the mid part of your, so from one side, aram se. So once you pass the needle on another side, then you make a knot in this way. Everything have their own systematic way. Like if you fix your knot, not like this, it through the long axis of your assembly, and you just wait for few seconds just to transmit the force of the knot, and then again the double knot like in this manner, and then again one more knot. So this is the way by you fix this all your assembly 3 structures. Now we need another more suture from all 5 structures. So I think it is better towards from where you stand in side from the patient. So first I hold this my upper lateral, and don't more down, not here. It's the on top of the upper lateral cartilage, because otherwise it again block the internal nasal valve area. So on the top like this, and then now because all 3 structure are the fixed, so you can hold it and from the one side to the another side, and then in this way. So in this way you pass your needle in all your 5 structure, and then again in this same manner. So if you have a straight needle, then it's a better, but you can do this needle is also straight, like I learned this technique from the Pradeep Goyal sir. So it's a basically horizontal mattress sutures. What is that? It's a basically horizontal mattress sutures. Now the important thing, now if you have this axis thread, so never you pull just for saving this external thread, otherwise the whole assembly is disturbed. If you can pull it, if you want to pull it, then if you fold it only in the before to pass the needle from down this sides. Now we fix it. So this is the simple way by which you remove this needle. So by you can fix your spreader. Cut it. So this is the fixation of the spreader graft. Now another important thing for the spreader, then suppose your dorsum is tilted like this, So towards the bending sides, towards the concave side, because this side you have the more force. So on this sides you have the bigger spreader, and on this side you have the short spreader. So in that case you have the different size the spreader grafts. Now on the lower part, upper part of the spreader is under this nasal bone, and the lower part of the spreader graft till the anterior septal angle area. This is the anterior septal angle, the angle between the dorsal septum and the caudal septum. So this is till the end of the anterior septal angle area. But now if you need your lengthening of your septum, if you need the lengthening of your nose, then you can extend this spreader graft. Or if you want to make, if you have a deficient on the caudal septum, and if your patient have a droopy tip, a small piece dena. If your patient have a droopy tip, or if your patient have a binder syndrome, in that case, if you make a big cartilage here, and then on both sides of this one, you can do the spreader for getting the better support for the dorsal strut. So this is the different manner by which you can make more rigid assembly for the tip definition and the tip support. So you can extend your spreader. In that case, we say this spreader is a extended spreader graft. So first you analyze, and according to need, you make the ideal shape. So this is the spreader graft. Now there is another term, that is the spreader flap. What is the spreader flap? वो देना एक बार, periosteum. Give me the periosteum. So after the hump removal, sometimes tooth forceps, after the hump removal, when you remove the hump or from this septum, then you have this excess part of this upper lateral cartilage. So what will you do? Then you separate this perichondrium, separate this perichondrium, you separate this perichondrium. ये धागा हटा दे, अब स्प्रेडर तो हो गया ना, अपने को ये धागा हटाना है, नाइफ देना. I remove this suture because now we demonstrate the fixation of spreader. So I remove this one. So what will you do? First you separate this perichondrium, and then now, because after the hump removal, if you have this excess upper lateral, then what will you do? You just hold it. वो देना, cartilage holding. By cartilage holding forceps, if you hold it and it rotate it, this cartilage rotate it like this. Suture dena. Yeah, is folded itself, and then make suture from itself, from medial to lateral or lateral to medial. I think the lateral to medial is good. Otherwise, the knot create the problem. इसको hold करना. So by the spreader flap is also the function of the spreader flap is the same like the spreader graft, but if you have the over wide mid vault, then you can reduce the width of the width of the this mid vault. And sometimes if you have the scarcity of the cartilage, then you can use this axis part as a spreader flap. So you can put 2 or 3 suture in this way, and on another side, contralateral side, the same, and then you can suture tooth forceps. Then you can suture it with a septum. So this is the spreader flap. So after the spreader graft and the spreader flap, one more thing by which we can increase the cross-sectional area and the adjuncting technique for internal nasal valve area corrections, the flaring sutures. What is the flaring suture? So in flaring suture is basically horizontal mattress sutures. In flaring sutures, you pass suture in the this upper lateral cartilage. First pass this upper lateral cartilage from one side to the another side like this. From this, then again on another side, just same is a horizontal mattress suture, and then again from that side from the lateral surface of this upper lateral, and one more suture so this one more suture, note you always try to make your assistant that perfect, then there are so many things is. Now look that by this suture, by this suture, you can you can just change the direction of this upper lateral. So by this suture, you can laterally and superiorly lift up the upper lateral. So you increase the cross-sectional area of the internal nasal valve areas. So this is the technique by which you can deal the pathology of the mid-vault and pathology of the internal nasal valve area. Now, after the modification of the bony vault and the mid vault, the lower vault, how can we modify the tip? So for learning the modification of the tip is really a challenging surgery after the osteotomy, because tip also have a endless anatomical variations. So first you learn exactly the thorough knowledge of the this LR cartilage anatomy and the understanding the dynamics of the tip. Then how can we change the tip? So for understanding and for the simplifying the tip surgery, first you learn the tip characteristics, that what characteristics of the tip. So the tip characteristic is the first is the volume of the tip, and second, that is the definition of the tip, and the third is the width of the tip, and the fourth is the projection, and the fifth is the rotation of the tip. These all 5 things first you understand, then you can correct the tip. Volume of the tip, that means that refer always the area of this size of this upper lateral cartilage. Suppose your patient have a big volumic tip, then it means you have to deal this part of the lower lateral cartilage or LR cartilage. Then you can correct the volume, you can reduce the volume of the tip. Okay. Then second is the width of the tip. So for the width of the tip, you can know about the intermediate crust and about the dome, because by dome modifications you can reduce the width of the tip. By this way you can reduce the width of the tip. Then another important thing, if you want to getting the more definition, more angulation of the tip, then if you know, then you modify this dome part and you increase this dome angle, and then you have to find the better angulated tip. Then another important thing, one is the projection and another is the rotations. There is very confusing terms, especially for my junior colleagues and beginning for the rhinoplasty, but never buys. It's very simple. Projection, that means by which the notch, this notch project from the face. Like this is a distance by which the notch project from the face. The distance from this elafacial groove to the tip, this distance is the projection of the nose. So there are so many maneuver by we can increase the projections. Like the you put some graft here, there is the plumping graft, there is the pre-maxillary graft. You can put from this side to here, you can increase, like you increase the projections. And another way, you can make a big cartilage piece here, so increase length of this part by the, that we say the columella strut. So by strut you can increase, or you can use different type of the tip here. So these are the different ways to increase the projection. So this is the projection. Then the last is the rotations. What is the rotation? So rotation is basically angle. Rotation is a inclination from the nose, from the face, like the nose rotate upwards or like the downwards. So this is the angle from this nasofacial groove to the tip. So these 5 tip characteristics, first you understand volume of the tip, definition of the tip, width of the tip, projection of the tip, and rotation of the tip. Then you can manipulate the tip. So now there are so many techniques, but I think in 95% cases, by this 4 step or 5 step, you can manipulate your tip. Which is these 5 structure? First, that is the columella strut. Second, for the reduce the volume of your nose, the cephalic trimming. Third, for decrease your width of the tip by the interdermal suture. Fourth, for getting the more definition that the dome creating suture or the intradermal suture. And fifth, that the tip refining graft on this dome area. Either you can use the diamond graft, either you can use the sealed graft, either you can use the cap graft. So these five step, by this 5 step, I think you can deal the 95% primary tip deformity. So rest of 5% you never go for the 5%. This is my personal advice to my junior colleagues. First, you deal the primary tip deformity. Never try to do the secondary cases or asymmetric cases or the where you need the structural graft or there is a lot of other things, because for the 5% you need the tongue in groove techniques, you need the lateral crura strut, you need the elabaton grafts, you need the septal replacement graft, you need the septal replacement graft. So first you learn the first 5 these steps. So first we put the columella strut. So for straight, the septal cartilage is the best choice, and in the septal cartilage, the warmer part of the septal cartilage is the ideal, because the width and the length and the thickness is ideally for the columella strut. Again, the ideal length of the columella strut is the 20 millimeter and 2.5 millimeter the width, and the 1 millimeter is the thickness. So you first make the ideal size, because when you put the columella strut, then you have the 3 steps. First, the ideal make the shape, and then second is the insertion, and third suture fixation. By these 3 steps, you can fix your columella strut. And what is the goal of the columella strut? The goal of the columella strut, just for the tip stability, for the tip projections, and for getting the better definitions. So how you put it? First, just you take a scissor. First you take a scissor, and I think it's the better if you take the curved scissor, and you ask your assistant, you pull the another side of the medial crust, hold it. इसको पकड़ना यार, पता नहीं क्या तेरे को. You hold it another side, and then now you make a pocket. You finish your first step, we make the ideal shape. Then in the second step, we make a ideal pocket. Look that this is my pocket. This is my pocket. This is my pocket. So you create a pocket. Now, after the creating the pocket, you insert it. You insert this cartilage, and there are so many. Sometimes my junior colleagues confuse that how much we insert in the pocket and how much depth of this pocket. So I think it's better if you left some tissue or the anterior nasal spines between this strut and the anterior nasal spine, so that you have a better fixation of your strut. Otherwise, later, if you fix directly on the anterior nasal spine, then what happened later, your patient click, or doctor, my nose is click sound when I put it my finger on this one. So it's better you left some small tissues on the anterior nasal spines. Okay. So now again you put it between this. My pocket is little bit small, so I cut it, or you increase your ideal length is, sir, is 20 millimeter long, yani 2 centimeter and 2 millimeter width and 1 millimeter thickness, and that's all criteria complete in the warmer part. So now just after the shaping, after the inserting. The third is the fixation. How you fixate your strut? For fixation your strut, just you take a cartilage holding forceps and ask your assistant, like if you pass a needle. Now the important thing, where you pass the needle. No. Where you pass the needle. So you pass your needle just at the domal end, on this junction of this domal part and the infralobular in intermediate crus. इसके ऊपर लगाना हाँ, yes. So from the one side to the another side, this is the ideal side for the needle insertions for fixation of your strut. So now after the fixation, you can use one more needle according to your preference. Once you have become a rhinoplasty renowned surgeon, then there is no need to put the needle. Dr. Foda, they fix that direct. There is no use the needle fixations. Now for the fixation, you use 50 PDS. Sometimes when your patient have a secondary notch, that means the patient have earlier history of operative procedure, and the revision case, that means you case that operated by the same surgeon, that is the revision case. So when a patient have a secondary case, then you use the rib. Then sometimes in the rib, if you have the difficulty the passing the needle, then you can use for one suture the 40 PDS. But ideally the 50 PDS is good. So with मेरे को 40 बहुत आराम से जाएगा. So the important thing for this passing of needle for the first suture is the entry and the exit of your needle. Look that the end you hold cartilage holding. You hold your assembly and you pass your needle from one side, from this side to another side. Now the important thing, your exit and your entry and exit is on same plane. Otherwise, if your plane is changed, then your tip is deviated and your strut is deviated. So you pass the needle from from another side to on this side. So the entry and exit of your needle is the same. Now you fix it. Again, the important thing, you never fix it like this one. This is the wrong way. You fix it like this one. Everything in rhinoplasty is important. How you hold your needle and how you fix your knot. So this is the fixation of my strut. Cut it. You can use one more suture for the fixation. You can one more suture for the fixation here. So this is the strut fixation. And your strut, the important thing on the top, never beyond the dome. Never beyond the dome till the level of the, and how much you pass your strut in this pocket. For the beginners, I think if you can mark your strut between the mid part of the strut, then till the marking you can push inside the pocket. So this is about the columella strut. Now the another important thing, that is the sutures, that is the dome suture. So for the dome suture we have the two suture. One is dome creating suture or the intradomal suture. So in intradomal suture, how you fix the intradomal suture? Then you always use this cartilage holding forceps. You hold your domal part and twist it like in this way. So you hold this one, and this suture is a horizontal mattress suture from medial side to the lateral side, and never on just on the margin. It's the just cephalically oriented. So again, from just medial, lateral to the medial. You pass your needle and you ask your assistant, then you hold it. And once you hold it, then you make a, उसके अंदर वो आ रही है. So you fix it. So look that the difference between the two dome. So this is a dome creating suture or intradermal suture. Cut it. So on another side, the same from one side to the another side. In rhinoplasty surgery, you need a lot of patience. Sometimes if you are entering exit of the wound is site of the needle is wrong, then you can change it. So in this way, you fix. So this is the way for the dome creating suture or intradermal sutures. Now, next suture, that is the interdermal sutures. You never confuse between the intradermal suture and the interdermal sutures. In my fellowship course, there are lot of time the student they ask that they confuse between the interdermal and intradermal. When like the intradermal suture, then intradermal suture that is done on the same dome, but interdermal suture from the one dome to the another side dome. Like a, so this suture connect these both dome. Like a intercity express connect the two cities. So you never confuse, you never forget it. So interdermal suture, that the suture that fix connect the both sides of the suture, both sides of the dome. So now this suture, now look that. So we decrease the width of the tip by this suture. You can also place this suture just anterior to the strut also. But this interdermal suture is not too tight or the too loose. If you have the too tight of the interdermal suture, then what happened? You have a single point tip. Ideally, we need the two tip defining point. Then you have a tent deformity in the patient postoperatively. So remember that when you put the interdermal suture, then not too tight or the too loose. If you have the too loose interdermal suture, then the width of the tip is, your tip is wide. So these are the interdermal suture and the intradermal sutures. Now, the last thing, that how you reduce the volume of the tip. How you reduce the volume of the tip? So for reduction of the volume of the tip, we just excise the cephalic part of the this lateral crus of the upper lateral cartilage. 15 number. So caliper dena, caliper hai, caliper. So the important thing, we excise this cephalic part of the upper lateral cartilage. वो नापने का. Okay, so lateral crus part. So the important thing, how much you remove, that is not important. How much remove, that is not important. How much you preserve it, that is more important thing. So for these things, you should first assure that at least, because in Indian patient, we have very thick skin. So If you remove too much upper cephalic part, then post-operatively, this patient develop the ala retractions, collapse of the ala, and consequently, the patient develop the external nasal wall insufficiency, because this external nasal was laterally boundary formed by this ala, and the medial boundary formed by this columella. So if you remove the axis, then you create the heterogenic deformity later. So you measure it, at least you preserve around the 8 millimeter or 10 millimeter. So rest you mark it, and then after marking, we just excise the cephalic part. So we make a incision here on the cephalic part, and you preserve the dome notch area. So, and sometimes for the excision of this, you use the fine scissor. Sometimes if you're getting for the excision, getting the difficulty in the plane, then you can infiltrate in this vestibular skin area for better hydrodissections. You can then you can find better hydrodissections and better plane. So we just excise. And important thing, you never make a buttonhole in the vestibular mucosa. So this excise part of the upper lateral crust is always try to preserve it, because it's a very flexible part, and if you need the tip refining graft, then you can use it. So in this way we excise this part, so according to the need we can reduce the volume of the tip. So by the columella stud, by the dome creating sutures, by the interdomal sutures, and by the cephalic trimming, we can do 95% tip deformity. But in some case, सीजर देना, एक मेरे को और देखना, tip refinement grafts. In out of all these grafts, a common graft that is frequently used in a thick skin patient and in a droopy tip, that is shield graft. So first you make the shield graft. For making the shield graft, you make the ideal site. इधर भी करो, इधर भी करो. Whenever your patient have a very thick skin, then after putting all these things, you can make a ideal shape, and then you put a shield graft. Then how you put it? You just get a needle, and first you pass the needle, shield देना उस पे रख के, and you put it like in this manner. Forceps. In a thick skin patient, and you pass this needle from, you hold this one, and so in this way you fix by a suture this part by this part, and this part, this shoulder part by this one. You fix this one, and this part just above the stud, that is around 2 millimeter. So for getting the more definition, this is the shield graft. एक सीजर देना, सीजर देना, इसको खोलेंगे. Now after the primary cases, suppose in some patients, like if your patient have a deficient this caudal septum, and you need the lot of support in the distal third of the nose, and you want to correct the projection and the rotation in the same, then you need the septal extension graft. So in the septal extension graft, you need a big piece of the cartilage, and just you make the ideal shape around the 30 millimeter and the 25 to 30 millimeter long cartilage according to the need, and then you separate the medial crust both sides. This is the way by which when you need the more tip stability, and suppose you need the more definition, then this part of the cartilage you fix with the rest of the native septum. You fix it, you overlap with this septum according to your need. Then how you fix it? Now, if you want to lengthen your nose, then this part is more anteriorly. Then if you, because this septal extension graft is a very versatile graft. Okay, so if you want to lengthen it, then you fix it and long it. And if you want, suppose if you derotate your nose, then you can change the direction like in this way. And if you want to more rotate your nose, then if you go in this like way. And if you want to get more projections, then you can increase length of this one. So this is a very versatile graft. Now how you fix it? Then once you overlap it, this is a common way. Either you can also fix anterior end to end also like this one, but that is the little bit tricky from the margin to margin, because this overlapping, it's easy. We fix it by the mattress sutures. So give me. So before to the mattress suture, it's better you pass a needle from one side to the another side and ask your assistant, he properly separate the medial crust. So you pass the needle and you fix first is, and then fix by the horizontal mattress suture. You pass needle from the one side to the another side. You need the 2 or 3 suture. It's a very important graft in the binder syndrome, in the binder cases also. In that case, in binder case, the anterior part of the dorsal septum, anterior part of the caudal septum, in almost every case is deficient. So first you make in the septal replacement graft or septal extension graft. When your anterior caudal part of the septum is totally absent, then you use this cartilage piece as a septal replacement graft. Never confuse about the septal replacement or septal extension graft. And if you have a good dorsal or caudal part of the septum, then you use the small piece of the cartilage, then use the septal extension graft. So this septal extension graft is a very versatile graft. You can increase the height of the tip, you can increase the length of the tip, you can rotate your nose, you can derotate your nose. Now, another one important technique for change the tip, that suppose your patient have a hanging columella. There is a lot of patients, because ideally in the morning we saw in the lecture that the columella show, that means the distance between the ala and the columella, that is around the 2 to 4 millimeter. If more than this, then hanging columella, and then less than this, then there is retracted columella, or maybe retracted ala or hooded ala. So ideal columella show is 2 to 4 millimeter, but sometimes the patient have like a long infratip lobule or long this columella. Then how you correct it? Then it's a simple way. That is the technique is you just replace this medial crust part with this native septum posteriorly. So that is the tongue in groove technique. That means this part is the tongue, that in this groove, that we suture it and we replace it between this both of the septum. See, needle dena. So you can fix it, this medial cross, from one side to the another side, and you make a suture. Then you just correct your hanging columella by this tongue in groove techniques. But it's very important you learn the concept of the every techniques, because every technique when you do, then they have the another the change the concept of the tripod of the Anderson. So if when you do the tongue in groove, then the sometimes the node is derotate. So all these concepts you should keep in your mind. So this septal replacement, septal extension graft, and the tongue in groove techniques for correction of the rest of the 5% tip deformity secondary cases. And another one important, when sometimes the patient have a different type of the deformity, like the patient have a depression on the sella, because this relationship
Well,
between
take leave. Hey, you are doing great job.
Thank you, sir. Thank you.
Okay.
So this dome and this lateral crust have a relationship. This lateral crust part is the convex part. But sometimes look at what happened. This lateral crust have a paradoxically contour irregularity. That means this lateral crust have a depression like this. So patient develop a depression on this. And in your OPD, the patient come, doctor, I have the depression on this part. Okay. So how we correct it? Then in that case, give me the seizure. You hold it. फाइन सीजर चाहिए, फाइन सीजर चाहिए. In that case, you separate this underlying vestibular skin and then free this lateral cross, and then after free this lateral cross, you cut it sectioning from the dome part and we rotate it. So the concave shape of this lateral cross is just change it and we correct this deformity. So this is a lateral cross flip technique that is a very good technique. And another, when the patient have a external nasal patient have the external nasal wall insufficiency, in that case we use the lateral crura stud graft. So what is the lateral crura stud graft? Give me the seizure. इसको सेपरेट तो थोड़ा सा करना है, इसको पकड़ के रखो. Because in the cadaver, so it's little bit tricky. ये बहुत वो है, एक वो देना, पीस देना. है ना. This is a female patient, so the lateral crust is so flimsy, but I just demonstrate, give a long piece of the cartilage. Give me the seizure. Seizure, give me the seizure. ये निकाल ले, ये निकाल ले, ये निकाल ले. Cut it. Boss. So now this is the last maneuver by which we can change the external nasal wall. So this is the small piece of the cartilage. So we make the ideal shape for the lateral crura stud graft. There is two important graft. One is the lateral crura stud graft and one is the Ella batten graft. So the difference between the two graft, never confuse between them. If you want to put the lateral crura stud graft, then one end of this graft, one end of this your graft, another give me this one end of your graft that put if the inside after the separation of these skins, between below, you create a pocket and you put below the lateral crus. Then that is the lateral crura stud graft. And another end of this graft is your just at the end of the pyriform aperture like this. So this is the lateral crura stud graft. But if this medial end of this graft is put directly on the lateral crus, that is the ala batten graft. So never confuse between the ala batten and lateral crura stud graft, because lateral crura stud graft we put between the lateral crus and the this skin, so that for the support of the extranasal wall. So this graft we use for the ala support when the patient have the ala retractions. So I think we just learn or demonstration. So all the major maneuver, major techniques, and the gross all anatomical things. So if any persons have any questions, any query regarding any anatomical important landmark or any other particular type of the sutures or particular type of the graft, because sometimes there is the knowledge is endless, so there are so many things, the never ending. However, you have the any query in your mind, you can ask regarding the rhinoplasty. So, Amar Singh sir, I think they left, no? I think they left. So, I think we just conclude or we just wind up it. And thank you for the watching and continue with me. We just try to learn short tips and tricks for especially my junior colleague friends. And if you want to see later this then you can get the recordings also from the Infomedia. So we provide that link also. So thank you for the attending and keep the patience for this time. Thank you, and thank you Santdeep Pon sir and Amar Singh sir, Lokesh sir, and my especially heartfelt again thank to Dr. Tarun Oja boss and entire team of the boss that last 3-4 days they continue doing the good job for the very short notice. And my mentor Pradeep Goyal sir, thank you.
Thank you so much, Dr. Sunil Tawar sir.